Here at the Hawaii Dermatology Seminar, I'm speaking with Dr. Jonathan Silverberg of Northwestern University, who is a co-author of some very recent expert consensus guidelines on when to do patch testing, contact dermatitis patch testing in the setting of atopic dermatitis. Why the guidelines? What's the impetus?
Sure. So we know that there's a lot of overlap between atopic dermatitis and allergic contact dermatitis. And for many of our patients with atopic dermatitis who have more refractory disease, they may have at some point developed an allergic contact dermatitis along the way, where as long as they're getting exposed in an ongoing fashion to those allergens, that may aggravate the disease, make it more severe, and put them at risk for being really refractory to standard of care and require more aggressive or systemic treatments. And we certainly see this clinically quite a bit, where many patients who have very severe disease, and the next step would really be to go to some stronger systemic agent. Sometimes when we patch test them and we can find a relevant allergen for the patient to avoid, within a few months their disease just goes down a notch, gets much better, and really starts to respond to topical and more conservative approaches much better. But there are other scenarios as well where patients may often respond beautifully on most parts of the body with respect to the treatment of their atopic dermatitis. And so, the parts of their disease that will flare up in the winter time, the creases of the elbows, back, and knees, may melt away with a mid-potency topical steroid. But then there may be certain areas like the face or maybe on the hands that just don't respond quite as well to treatment. And that raises a big question of perhaps there's also a component of allergic contact dermatitis as well. And so often those kinds of refractory localized distributions will prompt us to do the patch testing. And so the guidelines really sought to sort some of that out and really, elaborate on those scenarios where it makes sense to patch test. They're not absolute black and white approaches, but they're really meant to give guidance to clinicians where, to try to sort some of these challenges out and to give guidance on some of the best practices for how to do this.
What would be some examples?
Well, for example, we have a number of patients who may be severe enough that they warrant some systemic therapy, like either systemic steroids or some systemic immunosuppressants. That can actually give you false negatives on the patch testing. And so the idea is you need to have a washout period if we're going to be able to successfully patch test. And trying to give guidance on what that washout period should be. So we know that, for example, with topical steroids, ideally about a week or so would be a good idea to have patients not applying topical steroids to the areas where the patches will go. But for systemic therapies, in an ideal world, we'd like to say somewhere around the 3 to 4 week mark of it being totally out of their system. But sometimes when you're desperate and you don't have the option of being able to keep them off it for that long because they might flare, that you could even be able to do it after 2 weeks of a washout period. And so the consensus approach, because we lack some of the important data points to fill this in, the idea was really to get the experts weighing in and trying to provide a consensus for a path forward.
Is it the standard patch test panel? Or?
So that's a great question. We don't have great consensus with this. For right now, we essentially suggest that using the standard screening series that we would use in every patient that's getting patch tested would be a good idea to use in the atopic patients. But we also know that for some of these allergens, there can be false positives and false negatives in the atopic dermatitis patients. And so we definitely need more prospective studies to sort some of that out.
Is there an occupational element of risk, like cement workers and metal workers?
Absolutely. So those occupations are certainly going to make a difference with respect to what type of exposures the patients will have. So, if we assume that the impaired skin barrier in atopic dermatitis will predispose to allergen penetration in the skin and priming the immune system for developing contact dermatitis, what they're exposed to will make all the difference in the world. And so in that occupational setting, if they're getting exposed to lots of cement, you may see allergens like potassium dichromate. If they're metal workers or welders, you might see more nickel allergies, right? And so it really all depends on that context. And we've seen fascinating differences in terms of the allergens that patients are reacting to, but many of the themes are fairly consistent in that, the atopic dermatitis probably preceded all of those allergies and perhaps put them at risk for it. But then once they had those allergies develop, that then aggravated the underlying atopic dermatitis, and it became this vicious cycle.
And what about home use products to make oneself more beautiful?
Absolutely. Well, certainly in our atopic patients, our patients are using many more moisturizers and over-the-counter products to begin with. But of course, across the whole spectrum of personal care products, we see a lot of this, that patients are developing allergies to ingredients in those personal care products. And again, they may have gone for years, they may never have had that allergy for extended period of time. But with that frequent repetitive use and exposure to these different products, eventually that can catch up to them and they can develop allergies to that.